Hey guys, Woodruff here. So this next video is going to be another long lecture, and this is over chronic musculoskeletal disorders. So in the last video, we excuse me, we talked about acute musculoskeletal disorders, things like fractures that come on suddenly. And so this we're going to be going over a lot of arthritis and other chronic problems that can happen with both your bones and your muscles that are such an important support for your body. So let's first work or look at chronic low back pain. Oh, and real quick as a preface, this is a long lecture. So if you're looking for short, sweet, simple videos, I would go under playlist and go under unit 3, and you should find other really simple videos that kind of break down more of these disorders versus I'm going more in depth. This is a long lecture. If you're not in my class, or if you just really enjoy painful long lectures, or if you're in my class and you want to go back and look at something a little more in depth. So anyway, chronic low back pain. So to have chronic low back pain, you have to have back pain that lasts longer than 3 months, because we talked about acute low back pain that may be from an injury. Chronic can be from a chronic strain. It could be from other, like you can see here, like degenerative disc disease, which we'll talk about, arthritis, osteoporosis. It can also be from an injury, and then like weakness, and that if it's not taken care of, like it's saying here, it's usually progressive. So it's not like you wake up one day and you have chronic back pain. There's other stuff that's contributing, leading to it. One of the most common causes is what's called spinal stenosis. And this is, what do you call it? Because you'll see here, it's not just, because like before it was acute back pain, this is chronic low back pain. And so, the key to remember here is we talked about with acute back pain is that usually it is the low back, because it's really easy to injure it, because that's where we keep all of our weight. But anyway, here, getting back to spinal stenosis. So this is one of the most common causes of chronic low back pain, and it's a narrowing of the spinal column. And you can kind of see it here in this picture, where like normally there's this great space, but there's this narrowing of the spinal cord, and that puts pressure, which then can create actual issues like with functions, because you have to think about what your spinal cord does and how it's the highway to get messages from your brain to the rest of your body, but it also can lead to a lot of pain. So what can make chronic low back pain better? Physical therapy is super helpful, and a lot of people underestimate how helpful this is. A lot of people want to go straight to surgeries or other treatments. But there's a lot that can be done for chronic low back pain with physical therapy, exercises, strengthening, things like that. Stretching is super helpful for people with low back pain, body mechanics, which will, I want to say that we already talked about, but I can't remember if I talked about it in this. I want to say that I talked about it before, but if I didn't, we will talk about it in this video at some point. But it's a lot of the stuff, keeping stuff close to your body, not like bending at the knees, not at the hips, things like that, and not like reaching above your head. Taking regular doing regular activity throughout the day. If you're staying in the same position, it can lead to stiffness, which could lead to more pain, but also rest periods where you're not like, just constantly moving. And then assistive devices. So other things that are going to help support them. And some of that stuff is like, it can be as simple as the chair that you sit in at work and stuff like that, making sure that you have really good lumbar support. So that's kind of how we can help in general, but how can we treat their pain? So, most of the time we start with least invasive first. So we're going to do things like NSAIDs, or we may, increase to stronger analgesics like opioids if the NSAIDs aren't effective. A lot of these patients could get steroid injections, and steroid injections will work for a period of time. They can last for months or sometimes longer, depending on the patient, their age, etc. But these kind of more locally help to decrease inflammation, which usually helps with that pain. So a lot of people will get those steroid shots on a regular basis. So they're more local. It's not a systemic steroid shot, but it's an injection locally to the area. Weight reduction helps a lot, because again, I said that low back pain, a lot of it's because that's where we hold all of our weights. There's just a lot of pressure there. Heat or cold application, and just like I talked about with acute back pain, like for some people, the heat is going to be more effective. For other people, cold or putting ice on it will feel more effective. So it's really just up to the patient's preference. If there's no improvement, otherwise they may do surgical interventions, but something to kind of keep in mind here. What can happen, and this happens really often when you have a patient that's had a back surgery, you're going to notice that for majority of them, it's not their first one, that they've had multiple, because what happens with back surgery, they're in there, doing fusions or other surgeries to try to fix this pain, this problem, or the stenosis, whatever the cause might be. And maybe they work and fix some of the pain that the patient's having, but we're messing in the area near the spinal cord. So a lot of other problems can come up. So, I mean, as someone who used to work in a hospital where all we did was back surgeries, a lot of these patients, I remember them like they would, I would ask about what their symptoms were before surgery, and they're like, oh, I had numbness in my left foot. And I'm like, well, is that gone? And they're like, yeah, but now I have numbness in my right foot. Or, like there's something else, or like, hey, I had pain in my back. I didn't have any numbness in my feet, but now I have numbness in my feet. Or sometimes they had numbness in their feet, that went away, but now they have a different pain or stiffness, etc. So it's not necessarily an all do cure, other problems can come up. So it's just important for the patient to kind of know. And so a lot of these patients, they end up having back-to-back multiple surgeries, and it can be very hard on them. Alternative therapies, we talked about this. Well, no, actually, no, we haven't gone into neuro yet. So, but I'll talk about this a little bit more. But there's what's called biofeedback that can help with that. Acupuncture, acupuncture. I don't know if I said acupressure, and yoga and stuff like that is helpful as well for pain. So let's go into something more specific. So that's kind of talking in general about chronic low back pain. We're also going to talk about degenerative disc disease. And so, what degenerative disc disease is what you have these it's effectively like a shock absorber in between your vertebrae and your spine. And what they do is they help to provide a cushion. What happens in degenerative disc disease, as the name suggests, is that you lose fluid, you lose elasticity or flexibility, or some of that shock absorption to the point where your discs are having this destruction, which is called degenerative disc disease. I'm sorry, ate some popcorn recently. Anyway, so you can see here, like this is what a normal disc is supposed to look like, but other things that can happen are a bulging disc. You can have a herniated disc where it slips back and gets kind of pinched. A degenerative disc, you can see here, there's like a variety of things that can happen, where it's starting to break down. They can just get thin, etc. So this patient's going to look the same as a patient with low back pain. Their main symptom is going to be pain. The difference here is that they may have radiating pain. It may go all the way down, around their buttocks or below their knee, kind of straight down their leg. We're also going to do that straight leg raising test, which I have a picture on, which I talked about for acute back pain. But they also can, like I was talking about, they can have numbness and tingling in their feet, especially like some of them, it's to the point where they can't even drive. Like they are, it's not really safe for them to drive because they're literally going out and trying to drive and they don't have an ability to press, to feel their feet, but yet they're trying to press on a gas pedal or a brake. And then also just because of what, especially in the low back and what functions are around the lower end of the spinal column, they can have bowel and bladder changes, incontinence, retention, things like that as well. So this is that straight leg raising test. And remember, it's that, when they start to move down to 60 degrees, they feel like that pulling or that tension of their pain gets worse. So if their legs are up in the air and they're starting to put them down, that's where they really feel that tension. So that's just a sign of the nerve root in the bottom of their spinal column being irritated. So let's talk about conservative management. So if we're not going to do surgery, what can I do? This is going to look similar to the low back pain. Our goals here are to make sure that the patient can have adequate ability to take care of themselves, and this will get back to some of their basic functioning. So again, physical therapy, stretching, body mechanics, balancing activity and rest. And then, for this patient, and it can be the same for chronic low back pain. Don't think it's like, hey, only degenerative disc disease can have a brace, but, we may end up doing a supportive brace for these patients. We can also do heat and ice applications. Massage can help. There's also, in this picture, what's called a TENS unit. And a TENS unit is, it's an electrical stimulator. And effectively, when you're in pain, your nerves are sending off signals saying, I'm hurting to your brain. And this kind of kills off those signals so that you don't feel that same pain. Obviously it has to be used appropriately, and you know, because you can get these things, you know, on Amazon, etc. And if you don't use them properly, you can cause some damage. And then medications like we talked about, steroids, analgesics. And I'll tell you, for back pain, something that's super helpful is muscle relaxers. So a lot of times we'll use them together. Like if they're on pain medicine, we don't want them to just be on pain medicine. Muscle relaxers help a lot because a lot of these people have spasms in their back too. And then, like we said, the steroid injections, because they can get systemic steroids too with the degenerative disc disease, but most of the time we're given those local injections. It's going to be what's most helpful. For these last longer, like a lot of these patients, they may need all three of these things, but the steroids hopefully can manage them if they get the injection, you know, for a period of time. Yeah, that's why a lot of times patients with chronic back pain or degenerative disc disease, they need to work with like a pain medicine specialist, because they're usually on a lot higher doses. And you may see, like, there was one time that I gave, like, there was a patient that had such chronic back pain. They were on such high doses. I was like, this is a dose to like kill an elephant. Like, I've never given this high of doses, but it was something approved by their pain medicine doctor, and it was something that they were used to. But, you know, just know that their medications may be very high doses, and it's really important just to understand that while you may not understand why they need as much pain medicine, that's, you know, we believe what the patient tells us when it comes to their pain, and let the doctor make that decision about what's appropriate based on their condition and history, etc. This is why stuff like muscle relaxers are helpful, and we use other adjunctives and stuff too, and try to like do what we call multimodal pain regimen, where we put them on a variety of stuff. That way they're not just on the opioids, but we're trying to use other things to synergistically work together. So let's talk about surgery. So there's a couple different surgery options. Like I was talking about a fusion earlier, where they stabilize or fuse or fixate. Kind of think of when we were talking about fracture, where we talked about a fixation. It's the same kind of thing, except there's literally a fusion where they fuse sometimes some of the actual vertebral columns together to make them more stable. And then there's also a discectomy, where they decompress the nerve root. There's a laminectomy, where they take away the protruding disc. And so, you know, you don't need to know or go in depth into what each of these surgeries are. What you do need to know is, what do you need to do as the nurse after, if you're managing a patient that has this. So after surgery, your role as the nurse is to maintain spinal alignment. You want to encourage them to have proper positioning and turning. And what I mean by that is, this patient's going to be on spinal precautions. In other words, we don't want them twisting, lifting, bending. We want them to have a very neutral, straight spine. So they're allowed to sit up and things like that. But when they're turning, we like them to, like, their whole body has to turn with them. We don't want any twisting of the spine. So the two best positions, so that's what we call with log rolling, is when we roll them like a log. It goes as one unit together, their whole body, versus like their legs are twisted one way, their body's twisted another way. You do not want any twisting. But the two positions that are going to be best for their comfort and to help to maintain spinal alignment is either to be side lying with a pillow in between their legs, because the pillow in between their legs really helps to relieve a lot of their pain. So if you're taking care of a patient with back pain and they're struggling, side lying pillow in between their knees is great. Or knees elevated, if they're like laying on their like back, like if I was sitting in this chair, knees elevated with a pillow. So the biggest thing is, you always want that flexion in the knee. You never want them to have that straight leg. So like if you're someone who struggles with back pain and you're sleeping on your stomach, or if you're sleeping on your back with your legs straight, those are like the two worst positions to sleep in. So you also need to monitor and try to prevent complications as the nurse after this surgery. So it's possible for them to have drainage of their CSF or their cerebral spinal fluid. So you have to know that normally that's a clear color. So most of the time, if you see a clear drainage, you're not that worried about it, because, you know, you're worried about blood and other stuff. But for this patient, we're going to be worried about them having drainage of their cerebral spinal fluid. So what you're going to look for is, on your dressing, if you see clear fluid, or like clear drainage. And a lot of times what you're going to see is it's what's called the halo sign. What happens is that the CSF actually separates itself. So if they're having a leak, like let's say there is a little blood in it, they might have a little blood, and then you'll see like a ring, a clear circle around it. That's what's called a halo sign. Then you definitely want to notify the doctor. So it's okay. It's normal for them to have a little bit of bloody or serous sanguineous drainage. And they're allowed to have, you know, a mild amount. If they're having excessive, you know, bloody drainage, or they're saturating their dress, collapsing, or if they have that clear drainage, then you're going to be worried about a leak. And if that's an emergency, you want to let the doctor know ASAP. Like I said, with this surgery, sometimes we can fix one problem or cause another, but because we're in the lower back, which helps with a lot of the lower body, we have to think about possible complications. Like I said, we do really close neurovascular assessment. So those 7 Ps and 1 C, we are all about that for especially the lower, we're really focused on the lower extremities. So you're going to have serial of those. You might be doing them every 2 to 4 hours or more frequently, just depending on the patient. And so then we call then bowel and bladder, of course, that can be as a result of having like pinched nerves and other things, or kind of messing with everything we're messing with around the spinal cord. So you want to make sure that they're peeing and pooping regularly. These patients after surgery, they're going to usually be put on a bowel regimen, and you're going to want to encourage food and stuff so that they actually have something to poop. But yeah, so those are going to be your really priority assessments. And then getting moving. Now these patients, they're still hurting, even though they had this surgery so they'd stop hurting so much. It's going to hurt at first because we literally cut into their back. You know, getting up and getting moving, they will feel better. Just make sure that they're using the appropriate, they're maintaining spinal alignment and turning right. And most of these patients are going to need, like, out of bed, when they're out of bed, they're going to need to put a brace on. So usually what we do is we sit them up, like, so if they're laying on their back, then we log roll them on their side. They use their elbow to sit up, and then we'll put the brace on them on the side of the bed, and then they can get up. They don't need to wear the brace in the bed, but when they're up walking around, they need the brace. And that's in general, like same with the peripheral neurovascular assessments in general, maybe every 2 to 4 hours. You might not have to do them that frequently. It just depends, but I'm just kind of give you an idea that these are some priority things you want to consider. And not everyone's going to have a back brace, but some people are, and this is generally what you do. So after surgery, you know, we just want to do good pain management. Like I said, that multimodal stuff, the muscle relaxers, because they often have spasms, pain relief. A lot of times we'll use stuff like, we may even use some like gabapentin, Neurontin, some nerve pain medications as well. And then repositioning, because sometimes it's just all about finding that right position and getting lots and lots of pillows, steel pillows from your neighbor. All right, so that's back pain. Now let's get into arthritis. So when we're getting into arthritis, there are 3 major types of arthritis we're going to talk about. We're talking about osteoarthritis, rheumatoid arthritis, and gout. And now gout doesn't have arthritis in its name, but it is considered a type of arthritis. So we kind of we put all those 3 kind of together. So the important thing is when you have some disease processes that are similar but a little different, as we're looking through this, start to pick apart the things that are different, not the things that are the same. So first, who gets osteoarthritis? You know, what is it? And so osteoarthritis, osteo, think bone. It's this is a bone problem, and what's happening is that you lose that cushion. So just like in degenerative disc disease, where there's the breakdown of that cushion that helps support the back and the spinal column, this is where there's a loss of your articular cartilage or your joint cushion. You know, most often when we talk about osteoarthritis, we're talking about it's going to be in your major joints, like your weight bearing, like your knees and your hips are most common. We'll talk more about that here in a minute. But just to kind of give you an idea about where this is happening. Most people think arthritis is just something that everybody gets as they get older, but it's actually not a normal part of aging. But most people that get osteoarthritis are older. So there's a lot of the risk factors and stuff like that. Like, for example, one of the big risk factors for osteoarthritis is postmenopausal women. That just has to do with changes in calcium and hormones and stuff like that. Obesity or extra weight is going to increase your risk of arthritis. There's extra pressure on those joints that creates loss of that cartilage. Working professional sports, so even people that are young, healthy, etc., either maybe they had an injury that they never got treated, or you know, just from repetitive movement, kind of like it's talking about here, occupations that involve frequent kneeling and stooping. Same, there's a lot of sports that require that. It can increase your risk. And so this also means us as nurses are at risk for arthritis, and you'll see it's very common in the nursing profession. You know, one of the other factors I was kind of getting into is that any sort of injury that wasn't treated, and this is what happened to me, is that I was having some knee pain, And of course, first I thought it was a blood clot, not a blood clot. And, you know, they found that I had some, you know, maybe early arthritis, and I had an ACL injury, like, which is a, you know, a ligament in my knee that tore when I was younger. And you know, as a result of that, you know, now I have a higher risk for arthritis, or I have kind of like early onset of that arthritis as a result of that injury. Now, I did get that injury treated, but I was young. I did not keep up with physical therapy the way that I was supposed to. So this is just really, you know, a testament to how important, you know, keeping up with this stuff or encouraging your patients to follow through with therapies. So the other thing that you're going to want to look for differences between types of arthritis is what is the diagnostic testing. And the hard thing with osteo versus rheumatoid arthritis is there's only little subtle differences. So most people would probably say, hey, let me get an x-ray. And an x-ray is going to probably show you maybe some things, but you can't from an x-ray alone just say, hey, someone definitely has osteoarthritis. We have to kind of like rule out other things. But two things, sorry, excuse me, two things you might notice on a patient that has osteoarthritis on their x-ray is there's going to be, what do you call it? Decreased joint space. In other words, like you can see here, normally there's like a good amount of space here in between this bone. But, you know, here in someone with advanced arthritis, it's like bone on bone. It's like grating against each other. And sometimes you can even hear that, like in the assessment. We'll talk about assessment findings, but yes. Also, they might have what are called bone spurs or osteophytes. This is something they found in my x-ray was presence of some osteophytes. So you can kind of see here some bone spurs that can happen at the end of the bone. So then we need to rule out that it's not rheumatoid arthritis, and we do that through looking for inflammation, because I know you're probably thinking bone on bone, or people are like, oh, my arthritis, and it probably seems like their joints inflamed, but osteoarthritis is not an inflammatory condition. So their ESR, which is their erythrocyte sedimentation rate, is going to be normal. Also, we can check things like CRP or C-reactive protein. That's going to be normal. So there should be no signs of inflammation. And then, you know, to like confirm more about the inflammation, because rheumatoid arthritis has periods of exacerbations and remissions, so that maybe we didn't catch it when they were in acute inflammation, is that we also would check the color of the synovial fluid. And there's no issue with the synovial fluid. There's no inflammation in osteoarthritis, so it should be clear, which again shows there's no inflammation. So this patient, like I said, they're going to be things that are going to be different for this patient compared to other types of arthritis is they're not going to have any systemic symptoms. So in other words, you know, there's going to be no like in rheumatoid arthritis, they're going to have some general symptoms like fatigue, weakness, things like that. And like it can affect all other body systems. With osteoarthritis, it's just in that joint. And the joint pain is usually going to be relieved by rest. So in other words, the joint pain gets worse with activity, and it's one-sided. So like when people have arthritis, they'll be like, I have arthritis in my right knee or my left hip. It's not like I have arthritis everywhere. Now, I'm not saying that. They can definitely build up and get arthritis in more than one place, but usually it's one-sided, whereas rheumatoid arthritis is symmetrical. So like if I have rheumatoid arthritis, it'll be in my hands, both of them, or if it was in my knees, it'll be both of them, or my toes, it'd be, you know, all of my toes, both sides. Whereas osteoarthritis is one side joint pain usually. So in other words, you can have it in multiple places, but just because I have it in my right knee doesn't mean I'm going to have it in my left with osteoarthritis. So usually it's the weight-bearing joint. So again, the hips and the knees, and that's because there's more pressure, destroying more of that cartilage. They may feel more stiffness after resting, that crepitation, and that's that like grating or grinding sound of the bone rubbing against the bone. And then there's some special symptoms that you're going to find for osteoarthritis versus rheumatoid. And the way that I remember these is all the nodes are for osteoarthritis. And so you can think like the what do you call it? Osteoarthritis, like the O in nodes, maybe. Well, to help you remember that it's osteoarthritis, but there's what are called Heberden's nodes and then what are called Bouchard's nodes. And the way that you can tell the difference here is that Bouchard's nodes are here farther away from the end, where Heberden's nodes are in the joint that's close to the fingernail. So that's why I have Heberden's nodes. They're hanging at the end. They're hanging at the end here. And Bouchard's nodes, I have that they are in between this joint. So pretty much any Bouchard's nodes are going to be any of these joints here in the middle, where the Heberden's are going to be the one close to the fingernail. And I know it looks like an inflammation, but it's kind of like those bone spurs where there's it's just a nodule. It's not an actual inflammation of the joint. But this can happen for patients that have osteoarthritis. So what are we going to do to help them? So osteoarthritis, it usually can be managed. We always, again, start with least invasive first. And so we usually start with stuff like acetaminophen. Usually that's our first line for this. We need to monitor the dosing closely for Tylenol or acetaminophen because it's hard on the liver. So if they have too high of doses, then it can definitely lead to issues with, like toxicity and stuff like that. And also, since it's hard on the liver, they're going to want to avoid alcohol when taking that. We also might use, even though it's not inflammatory, a lot of people find relief through aspirin and NSAIDs, which are anti-inflammatories. We're going to tell them always to take those with food because they can cause stomach irritation and it can cause GI bleeding. So you want them to report any signs and symptoms of bleeding. There's also some topicals. So those that, use if you know what icy hot is, it's the same, the fancy name is capsaicin. They should use it at regular intervals, but something to keep in mind is they should not apply this and then apply a heating pad because pretty much you're going to end up giving yourself a burn from that. So, you should not use it at the same time as a heating pad. So apply that. And then, if you're going to use your heating pad, use it at a later time and make sure to clean off your skin first. Later on, as time progresses, depending on their function stuff, a joint replacement may be considered. People can have any joint replaced, but the most common ones are hip and knee replacements. And then physical therapy can help as well. So what do we want to teach these patients? We want them to have protect their joints and remain safe. So depending on which specific joint is affected, we'll create a care plan based on that to, kind of teach them what are the body mechanics, what kind of safe environment they need at home. They can do things like removing extra rugs so they don't trip, having rails in their stairs or in the bathtubs. Night lights help because these people are going to be more at risk for falling. And then making sure they have well-fitted supportive shoes. And we also do things to help them with joint protection or to conserve their energy. Because pretty much the hard thing is it's a mix. We don't want them, rest does help, but if they rest for too long, they get stiff. So it's a fine balance. But what we want them to avoid is that forceful repetitive movement. So kind of like us, leaning down and, bending our knees every hour to get an hourly urine output as a nurse, that forceful repetitive movement is not very helpful. So trying to find a way to split that up or use good body mechanics so you're not putting all the pressure on those joints that are struggling. Don't be afraid to ask for help. So if you if patients are struggling or have some tasks they need to do, they should start to lean and rely on people versus trying to do it for themselves. Pace themselves, not feel like when they do any task that they have to get it done quickly, and then modifying that work and home environment as needed. Patient education will give is, again, balancing rest and activity. Keep the joints in a functional position, so we don't want to be twisting, bending them in weird ways. They may need to use splints or braces. Sometimes that might help. We want to decrease any stress on the affected joint. So if they can use a cane, walker, crutches to remove some of the weight used on whatever limb is affected, it's great. Avoid any prolonged standing, kneeling, or squatting. So there's no position we want to stay in for too long. We really want to make sure that we're not putting too much weight on that joint, but also it has to be a balance. We don't want to just sit down all the time. Heat is good for stiffness. So generally what we say with arthritis is if they're in pain, put ice on it. If they're stiff, heat is going to relax that and help to allow for better joint mobility. Weight reduction for these patients, super helpful and can reduce a lot of their pain. And then we want to, of course, preventing osteoarthritis in general. Some of the other risk factors, things like smoking once again, is sadly not going to be the thing that saves the day. Anytime that you have a joint injury, getting it treated promptly and, like I said, keeping up with those therapies. Healthy weight, balanced diets, safety stuff to prevent falls, because remember, injuries are closely related to osteoarthritis, and then regular exercise to keep your mobility and everything together. So now let's compare this to rheumatoid arthritis. So I've kind of gone over some stuff with rheumatoid arthritis, but let's do a compare and contrast. So rheumatoid arthritis, in comparison to osteoarthritis, it's a chronic systemic autoimmune disease. So osteoarthritis is a bone disease. It's a bone problem. There's not enough cartilage where, they've lost the cushion. Whereas rheumatoid arthritis is actually an autoimmune disease, and it leads to an inflammation in that joint space. So it's not actually anything affecting the bone, it's the joint space, and there's inflammation there. And whereas osteoarthritis is a lot more common in that older patient, rheumatoid arthritis is autoimmune, so you're going to see it in a younger population, like 30 to 50. And it can lead to like a really, severe limitation. So that if it's not treated in the joint deformities or not taken care of early, they can lead to like severe inability to manage life on a day-to-day basis or take care of themselves. So let's look at the diagnostic studies. First, we have to see that, they've had symptoms that have lasted greater than 6 weeks. We can do a synovial fluid analysis. This is going to be probably one of the best measures. And whereas with the person with osteoarthritis, it's clear fluid. With rheumatoid arthritis, it's going to be cloudy or straw colored, which are signs of inflammation. We cannot really just look at an x-ray and be like, oh, it's rheumatoid arthritis, because remember, this is not a bone problem. This is an inflammation in the joints. But we may get it to look for injury or to rule out that it's not osteoarthritis, etc. And then a lot of labs are going to be really key for this patient, because we want to look for signs of inflammation and signs for autoimmune. So to check to see, pretty much we're looking for a presence, and it doesn't, the most specific one to rheumatoid arthritis is going to be the RF factor. But, there's other ones that we can get to, like the ANA or anti-CCP, etc. So those tell me, hey, there's somewhere in the body, there's some sort of autoimmune, or the body's attacking itself. The CRP and the ESR are those two that I talked about before, the C-reactive protein and erythrocyte sedimentation rate. And these two are both signs of inflammation. And so with these, effectively, with the inflammation, et cetera, that's what we're looking for, because this is an autoimmune disorder that leads to inflammation. So we're looking for those characteristics. They should have a positive or elevated CRP, ESR, and then they also should have the presence of a positive RF factor and the presence of anti-CCP. All right, so what does this client look like? Like I said, compared to the patient with osteoarthritis, this patient has systemic symptoms. So they can have fatigue and weight loss, and those are a result of the autoimmune, where the body is attacking itself, that leads to a lot of those symptoms. So those are generalized symptoms, and I'll talk about it here in a minute, but it can affect the whole body. There also is joint symptoms, and the difference here, of course, is going to be that compared to the patient with osteoarthritis, the patient with rheumatoid arthritis, they don't have a one-sided joint problem. It's symmetrical. So like I was saying before, if they have rheumatoid arthritis in their hands, it's going to be both their hands, not just in their right or not just in their left. So they're going to complain of pain, stiffness, limited motion. You're going to see signs of inflammation. So like their joints are going to look red, swollen, tender. It's most common, whereas, with osteoarthritis, it was the weight-bearing joints in the hip and the knee. It's most common in for rheumatoid arthritis in the small joints of the hands and the feet. They also can have prolonged morning stiffness. So when they wake up in the morning, I talked about how a patient with osteoarthritis can get stiff, after not moving for a while, but usually it gets better once they get up and get moving. For a patient with rheumatoid arthritis, they may have more prolonged, or even with movement, they may still feel pretty stiff. And I'll talk about what we can do for that. So whereas the patient that had osteoarthritis had all the nodes, the patient with rheumatoid arthritis can have, multiple deformities. So it's all the stuff with the D's. So there's ulnar drift, Boutonniere's deformity, or swan neck deformity. So let's look at these together. So you can kind of see ulnar deviation is kind of that outward deviation of either the joints or of the ulna itself. The swan neck deformity is, you can see here, like how the fingers look like swan necks. And the Boutonniere's deformity, you can see kind of where it's this outpoaching, that's not a word. It's the abnormal flexion of the thumb there, but it can be in other fingers and stuff well. But you can see when I talked about how the deformities could lead to a complete lack of ability to function, like imagine like all these things here, like you can see, like imagine trying to pick up a pencil, feed yourself. I mean, when your hands have that many deformities, it's going to be really hard to do that, which is why this one can really be debilitating. So rheumatoid arthritis can have a lot of non-joint manifestations, and it can affect every organ. So a lot of times people that have rheumatoid arthritis also have lupus, carpal tunnel, Sjogren's, other things like that. So just know that if a patient has this, they may do more workups to look for other autoimmune problems in the patient's body. So since we're dealing with an autoimmune disorder and an inflammatory disorder, we're going to give medications that are going to help with the inflammation, medications to stop the immune system from attacking itself. So there's a class of medications that are called M.H.D.R.C.R.D.H. These are specific to rheumatoid arthritis, and it stands for disease-modifying anti-rheumatic drug. And so they help to slow down the disease progression, decrease some of that joint erosion or deformity that happens. Some of the most common ones are going to be methotrexate and hydrochloroquine, which is also known as Plaquenil. There's also what are known as biological response modifiers, and these change kind of how your body is reacting to things. They also slow down the progression, and these are used once you get kind of more moderate to severe. And you can kind of see this table over here where we start with like anti-inflammatories and some of the M.H.D.R.C.R.D.H. And then as we go down, we're using some of the, more stronger drugs. And then other things that can be used, things like antibiotics, that certain ones can decrease the breakdown of cartilage. Gold preparation can decrease immune response, and then corticosteroids can also decrease immune response. And so, as a whole with these, we're trying to obviously stop them, like, because with autoimmune disorders, we're trying to stop them from having so many attacks. We're trying to slow down how often that their body is attacking itself. And then the anti-inflammatories help with their acute symptoms and problems. So some considerations with the DMARDs like methotrexate, these are, trying to stop the body from attacking itself. So we're kind of suppressing the immune system. So this can lead to what's called bone marrow suppression. So this is where, if you think about what your bone marrow does, it produces all your blood cells. So if your blood cells are being suppressed, you're going to be a higher risk for infection, higher risk for bleeding, anemia, and you can also have dysfunction in your liver and kidney with the methotrexate. There's another medication called sulfasalazine. Just know anything with sulfa a lot of times can cause an orange or yellow discoloration. And it's not critical or necessarily dangerous, but you want to tell patients because usually people freak out when their urine changes to some strange colors. And I know you might think orange is a normal color for urine, but it's kind of a bright. And so in the hydrochloroquine or Plaquenil, we really want to be worried about vision changes or any muscle weakness or changes to hearing. All those biological response modifiers, they're like, and pretty much in general, if you want to think about everything that we're giving for this patient, the big things we're going to be worried about are bleeding or other like blood cell disorders, and then we're going to be worried about a lot of the risk for infection. So a patient who's on biological response modifiers, they're going to be unable to take any live vaccines. So just as kind of a reminder, for a patient who is like a normal person that doesn't have any autoimmune conditions, etc., they can get any kind of vaccine because they have an immune system that's strong enough to support them to build up that immunity. So like if I went out and got like a flu vaccine tomorrow, like I have a strong enough immune system that even if it was a live vaccine and I'm getting a live virus, my body has the strength to do that. But if I have a suppressed immune system, my body can't handle that. Doesn't mean they can't get vaccines. It means that they can't get any live vaccines. They get what's called, an attenuated vaccine, or it's one where it's not a live virus that's getting inserted. It's one that it's hard to explain. I guess the best easy way to say is like a dead virus, but it's like they're still going to build up immunity to it. And this is what most people get. Like when you and I get vaccines, this is what most of us get. It doesn't make their immune system have to put on a full war versus start to get that immunity to whatever the vaccine is for. So what can we do for pain management, decrease inflammation? Because remember, we want to decrease attacks, but they also have pain and inflammation. So NSAIDs, because this is an inflammatory pain, are going to be better. So acetaminophen may help with pain, but since this is inflammatory, NSAIDs are going to be the preferred, medication here. Also steroids. They help in two ways. They help to decrease pain. And then also a lot of these patients can have problems with having a good appetite and getting good nutrition. So steroids also help to increase appetite. They can have a synovectomy, I can talk, or a total joint replacement for that joint, because remember, it's a problem in the joint space. OT and PT, especially OT, they need a lot of help doing their activities of daily living because of those deformities. We talked about having that prolonged morning stiffness. One thing that can help, remember I said for stiffness, is warmth. So if they start their morning out with a warm shower or a bath, it can help to relieve some of that prolonged stiffness. Making sure that they're staying ahead of their drug therapies, because their pain and their inflammation will be decreased if they're having less attacks. Make sure they're balancing rest and activity. And like I said, heat for stiffness, ice for pain or other exacerbations. So for these patients, we also want to do joint protection, but in a different way, because remember, these are different joints. So we're protecting the small joints more often with rheumatoid arthritis. We use a lot of things like splints and things like that. And our goal here is that we cannot necessarily prevent rheumatoid arthritis since it's autoimmune. A lot of times that's a lot of genetics there. But if we catch it early and we manage it well, we can decrease a lot of that joint damage and allow them to still have functional capacity. So keeping neutral positions for their joints are ways to protect your smaller joints, changing positions frequently, no repetitive movements, heavy lifting. You want to teach them to distribute weight over multiple joints, so slide objects instead of lifting them, and then use the strongest joint available for a task. So if like I was going to get up right now, instead of using my fingers to push up, it's using like the palm of my hand, to kind of push up, because that's going to be stronger than just my fingers. All right, hopefully you're still with me. We're almost there. So then there's also gout. So gout is another type of arthritis. You might hear it called gouty arthritis. This is different because instead of there being a problem in the, like with the inflammation in the joint space or a problem with the bone, there's too much uric acid. And what happens when your body has too much of something, it starts depositing it places, and uric acid loves to chill in the joints. So you have these swollen, painful joints that you get, but it's not necessarily because of an autoimmune. This is because you just have too much uric acid. And we'll talk about, here in a second what causes that. But effectively the uric acid that gets in the joints, and they have these periods of exacerbations and remissions. Obviously, when the uric acid builds up, it collects in their joints, but then when we get those uric acid levels back down, the pain and stuff goes away. So these people can go around, in their life, and actually, if they manage this well, and if they stay away from things that increase their uric acid, they can live a pretty normal life, and they don't necessarily have a lot of joint deformity or those day-to-day issues. But during those exacerbations, it can be incredibly painful. So for the last two types of arthritis, I've really focused on like, hey, they have to get up and get moving. Like this is a patient that when they have an acute attack, we're not getting them moving. They need to stay still, relax, and we need to let that pass, because it gets so much more painful when it comes to those acute attacks. And dangerous, I'll talk about it here in a second, for them to get up and get moving too much. So it can be hereditary, but most people, when they get gout, it's a result of too much alcohol use, having diabetes, kidney issues, because the kidneys are what get rid of uric acid. So if you have a problem with your kidneys and they're not letting go of them, that's what can happen there. And then high blood pressure as well. There's also medications that can cause you to hold on to uric acid. So things like thiazide diuretic, ACE inhibitors, or beta blockers as well. So we can diagnose this a few ways. Something to kind of keep in mind is that if you draw uric acid and like a blood test, it fluctuates throughout the day. So it's not the best measure. So you could sit there and be like, oh, your uric acid levels are high in your blood, but it could change, in the next hour. We can do a better measure would be to do a 24-hour urine uric acid to see how much is getting released, etc. But the golden standard that we usually use is a synovial fluid analysis, where they, they go in that, I want to say chamber, space in between the joint, and they aspirate some fluid, and inside you're going to find uric acid crystals. Sorry, getting to that point where it's starting to get itchy from talking so much. We may also get some x-rays and other stuff to rule out other problems. Usually their x-rays are going to be normal because remember, this is not a bone problem. This is a collection of crystals in the joint. So what do they look like? So their joints, and usually, like I should say, I'll start with this, is that usually the most common place that they get this is in their great toe. But it can happen in the hands and other places too. So, but usually it's the toes and the fingers, etc. But those joints, whatever ones are affected, are usually going to be dusty, cyanotic, or tender. There's going to be signs of inflammation or swelling. And again, this is not an inflammatory disorder, but because there's all this uric acid crystal, it causes irritation, which leads to inflammation. They can even have like a low-grade fever. And so like the TOFI or TOFI, however you want to say it, I'll show it on the next slide, but that's another sign. And it's the actual, it's like this, like the accumulation of crystals. Hold on a second. Excuse me. So I was talking about that we're worried about, like this patient can be normal, go around, not have deformities and other issues, but it's possible they can have complications, which is why during an acute attack, we really want to manage it. We don't want them, because these can perforate and cause a lot of issues. They can lead to infection. It can break down the cartilage if they're not managed well or taken care of early. Also, if you have a bunch of uric acid, you can get uric acid stones, which you can, I'll have lectures out soon, about urinary stuff too, which we haven't gotten to, but it's going to put you at risk for uric acid stone, uric acid kidney stone formation, and you can also have kidney infections as a result. So what can we do? So first there is inflammation and pain. So we can give the least invasive first would be things like NSAIDs, but we also need to decrease the amount of uric acid they have and reduce some of that inflammation. So during a during an acute attack is usually when we use this. This is called colchicine, and colchicine helps to reduce inflammation, and it prevents more attacks from happening. We got something just to kind of consider when you're giving this is that there can be blood in the stools or the urine, and there can be muscle weakness. Those are signs of sometimes a problem, so you want to monitor for that. But think colchicine is used during an acute attack, whereas to prevent attacks, like, I know it says here that colchicine can be used to prevent attacks, and yes, it can, but usually we use colchicine more in acute attacks. And then, like maintenance for a patient that has gout, they're going to be on what's called allopurinol, and this helps to reduce uric acid production in general. So like taking this during an acute attack is not going to it's not going to help with any of their symptoms right now, but the colchicine can. So for allopurinol, we want to tell them to take it with a full glass of water, monitor that liver function, because this can affect liver function, and it can lead to skin rashes too. So just let the patient know. But like I said, this is very manageable disease with medications, and then also with finding out what the cause is. So if the problem is alcohol, they need to avoid things, like with the drinking, you'll find that pretty commonly. But we also really want to look at their diet, because something that can lead to accumulation of uric acid is someone who has a very high purine diet. And so purine foods are going to be things like red meat and organ meats, shellfish, refined carbohydrates like white bread or white rice, any processed foods like chips, frozen dinners, sugary beverages, alcohol, etc. And so we definitely want them to avoid those foods and kind of get them on a diet that's going to help them so they're not accumulating so much uric acid. So that's really the goal there, is decrease inflammation, get rid of the uric acid, both through medications, but also through lifestyle changes. So I think this is the last thing, but I might have thermal. Do I have thermal on here? I might. Maybe, yeah, I think I have thermal on here too. We'll have to see. I can't remember. Or if maybe I did thermal and acute. It doesn't matter. I'm going to keep going. So let's talk about osteoporosis. So osteoporosis is another progressive disease, like we talked about with some arthritises, but this is one like people, when you're, people commonly get these mixed up when they're on an exam because they see the osteo and they automatically, kind of fill in the gap there that this is osteoarthritis when it's actually porosis. So when you're looking at this and you're trying to, like differentiate like osteoarthritis, You know, I always think this one aunt that I was always like, oh, Arthur, you know, like when she talked about the pain with her arthritis. But a good way to remember osteoporosis is think pore, like porous, like it's what do you call it? There's holes in it, like, you know, it's full of holes. And so compared to osteoarthritis, where there is an actual breakdown of the joint space, which leads to bone on bone. This is a problem in the bone itself, where it becomes holy. I don't mean holy like spiritual religious, I mean holy like full of holes. So when you think osteoporosis, think the bones are poor. You can think of poor, P-O-O-R, like they're poor, they don't have a lot to them, or porous, you know, like that they're full of holes. And so the big issue here with osteoporosis is that there are weak, fragile bones that are going to really easily break. So it's not an issue in the joint space with the bone on bone, it's an issue in the bone where the bones just are weak, fragile, unable to, you know, have a strong tissue there. So you can kind of see it in this picture, how this is a healthy bone versus osteoporosis. So osteoporosis is more common in women, and especially those that are over 65 years of age. And this is the only, but I don't know what to say it's the only, it's one of the very few disease processes where being a low body weight hurts. So in order for your bones to be strong, they have to have some weight on them. So someone who's a really low body weight, who's like really skinny or doesn't weigh very much, they don't have as much weight on their bones to create strength in them. So women greater than 65, lower weight, white or Asian ethnicity are going to be more at risk. A low calcium diet or a sedentary lifestyle where you're not moving around and not putting pressure on those bones to get them strong. Early on, the patient, you know, they may have no symptoms. This isn't something where like the patient's having pain often. Like they can have, like it's saying here, they can have like back pain and stuff like that sometimes, but don't like really don't think of this as like there's something going on, like because it's holy, they have pain, like that they're feeling something as a result of this. The main thing you're gonna see is that this patient comes in and they're just having like back-to-back falls and fractures and other stuff like that. Usually when we do x-rays and stuff of them, we're going to find all these healed fractures. Some of them they may not even know they had, but they're just having all these breaks in their bones. Later on, they can have a loss of height, or also what's known as kyphosis, kind of that like little hunchback appearance, etc. So when you think about this thick people coming in, they're having random fractures with no known cause. So diagnostic tests are going to be super important for these patients. We can't see a porous bone on an x-ray. Like, you know, this picture that I had in the previous slide, you're not going to look at an x-ray and it's not going to show that. So you can't see that. You can't look at bone density on an x-ray, which is why you need to do a bone density scan. But we may get x-rays just to see about the fractures. So the point of getting the x-ray is not to diagnose the osteoporosis, it's to see, are they experiencing a complication from the osteoporosis? But the best measure is going to be doing what's called a bone mineral density test, also known as a DEXA scan. So that could be either in a test, and you want to see how much bone loss is there. What is the bone density? And you can kind of see here, here's kind of an example of what this looks like. We also may get labs, but again, labs are not going to be telling. I can't be like, oh, their calcium is low, they must have osteoporosis. But we can look at it, and a normal calcium is around 9 to 10.5 per your textbook. And so a lot of times it'll be low. And we may also check other things because calcium and phosphorus work opposite. So if my calcium's low, my phosphorus may be elevated. And then also they can have low levels of vitamin D as well if their calcium is low. So what kind of education do we want to give them? We want to teach them about getting good calcium intake. So most people think of all of the dairy products, and yes, these are like, you know, some of the most common stuff: milk, yogurt, cottage cheese, ice cream, all great sources of calcium. But also know like things like spinach have good calcium too for those that just don't do dairy, because some people are just not good with dairy. So calcium supplements are also commonly given for these patients. And again, they don't necessarily fix the osteoporosis, but we're doing everything we can to strengthen the bone. So the thing to know about calcium supplements is they need to take these with food in divided doses throughout the day. Vitamin D supplements may be needed as well, because remember, you need vitamin D to properly absorb calcium. So vitamin D supplements, or getting out more in the sunlight, getting up, getting moving, exercise. But the exercise here, the specifics, is just like how they kind of need specific diets and stuff to increase their calcium. There's specific exercises. So just exercise in general general isn't helpful, but the best exercise, it's not that it's not helpful, but it's not as helpful as doing weight-bearing exercises. So the best exercises that we want for these patients are going to be things where they are putting weight on their bones. So probably the best one would be walking, but other things like hiking, weight training, dancing, anything where their legs are off the ground, or they're like swimming, you know, horseback riding, something where they're not actually putting weight on their bones is not going to be as helpful to these patients. The primary medical or medication that we do for osteoporosis is what's called bisphosphonates, also known as alendronate. We'll talk about that on the next slide. And then a big part of your teaching and work with this patient is going to be doing fall and injury prevention, because they're just going to be really high risk for having problems related to falls because their bones are so weak. So bisphosphonates, also known as alendronate or Fosamax, these are going to actually help to combat the problem, which is that they don't have enough bone mineral density. So it helps prevent breakdown of the bone and help to, you know, create some better density there. So there's special teaching with this medication because it can cause GI erosion. So we want them to take it first thing in the morning, usually with a full glass of water, empty stomach. They should not take it with any other medications. It should be taken by itself. And then to prevent that erosion of their esophagus, they need to sit upright for at least 30 minutes. If they lay down, it's a good chance of that gastric acid and stuff going into the esophagus and causing erosion. So remain upright for at least 30 minutes. Those are some really important teaching you want to give around the alendronate for this patient. Looks like we are going into thermal injuries. So thermal injuries is kind of a hodgepodge extra topic. You may be like, what does it have to do with musculoskeletal? But here it lies. So let's talk about heat-related injuries first. There's three main heat-related injuries we talk about. We talk about heat cramps, heat exhaustion, and heat stroke. And we'll talk about the differentiations with those on the next slide. But, you know, in general, heat-related emergency is a result of, you know, you've been exposed to heat for too long, for a long period of time, or there's been a brief exposure to some really intense heat, aka living in Texas. It's both apply. And the body gets to the point where it cannot compensate anymore. And the big things we worry about is fluid and electrolyte loss. People that are more at risk, those that are older, and those that are younger are more at risk. Those that are older are more at risk, you know, because everything goes to crap as you get older. And then babies, they don't have the same mechanisms, or it takes them a while to get to the age where they can regulate that. Anyone in a high temperature environmental climate, you know, like this summer, Texas and 100-degree weather for the, you know, record highs, you know, we definitely are at risk for heat-related emergencies. Then also having a history of cardiovascular disease, diabetes, obesity, or stroke is going to increase the risk. Using things like amphetamines, yet again, cocaine and other fun stuff does not help. So what does a patient with a heat injury look like? Like I said, there's kind of the differentiation here. It's progressive. You know, heat cramps are the least intense. Heat stroke is the most intense. So heat cramps are brief, intense muscle cramps, and they're a result a lot of times of those electrolyte and stuff imbalances from that dehydration and stuff. So, you know, what a patient might also have as symptoms, they might have nausea with this, their heart rate might be up a little bit, weakness, like sweaty. This is usually from short-term exposure to heat. They, you know, went out, you know, maybe watched a baseball game and you know, got a little overheated, might have some cramps. This can resolve on its own. Usually the patient doesn't need to go to the emergency room, anything like that, and it will get better soon. But if you, for some reason, they can't take in oral fluids, or it's not getting better, they definitely need to go in. Heat exhaustion is the next level where, you know, they're starting to have more symptoms. They're fatigued. They may be having some vomiting, extreme thirst, anxiety. They also can have low blood pressure, and their temperature can be anywhere from 99.6 all the way up to 105.8. This is from more prolonged heat exposure. So maybe workers that work all day out, you know, on the road, construction workers, etc., might be at risk for this. And again, if they can take PO, this can resolve on its own, but they may, a lot of them end up, you know, temporarily, if not nothing else, in the emergency room. And then there's heat stroke. And so this is the most serious one. And this is, you know, also what you would think of hyperthermia. Temperatures greater than 105.8. And these numbers are specific to the textbook. If you're watching this and you don't go to my college, yours might be different, but just kind of know this is what we use for my textbook. And they start having neurological symptoms. So it's a complete failure of the body to be able to regulate temperature, and it's considered a medical emergency. So what are we going to do for emergency management? We're going to manage their ABCs, make sure that they can breathe, they're getting good oxygen, that they have a blood pressure, that kind of stuff. Give good oxygen, the high flow oxygen to help, because their body is going to be using so much when everything is really hot. It's moving super fast. It's hard on the body. Fluid replacement is so key in these patients. Fluid and electrolytes for both of them, because they usually have pretty profound losses. A cool environment, so turn the room temperature down as much as you can. Remove any constrictive clothing. Try to keep them cool. You don't have to strip them down naked, but I definitely wouldn't be putting blankets on them, etc. Because of potential electrolyte imbalances, we need to get a 12-lead electrocardiogram or ECG. We need to check electrolytes on a BMP or a basic metabolic panel, and then look, we can kind of assess that dehydration through the H&H on a CBC, which is the hemoglobin and hematocrit. And then maybe insert a catheter, because we really want to watch that intake and output really closely. So for heat cramps, like I said, usually we just do not just fluid replacement, but also sodium or salt replacement, because you can, salt and water, they're best friends, they hang together, and lots of rest. And they may want to avoid strenuous activity for about 12 hours. But again, usually they don't need to go in necessarily to the hospital. Heat exhaustion, a lot of times these patients that usually end up in the emergency room, they need a cool environment, removal of constrictive clothing. We're going to look for dysrhythmias for them, because they can start to have some of that instability. Do the same stuff, oral and fluid and electrolyte replacement if it's tolerated. If not, they might get, especially if they're nauseated, we're going to go towards the IV fluid replacement. And then once they're at the heat stroke level, 100% O2, continuous ECG monitoring, we're going to do rapid cooling, internal and external. What I mean by that is we can lavage them through devices, when it's saying internal, we can give cold IV fluids and things like that. We put them in the fridge and let them cool down, and it helps to cool them from the inside. And then we can also put cooling blankets and stuff underneath them. IV fluids, and we won't want them to shiver, because if they shiver, their temperature is going to go up. So there are medications we can give that stop shivering. A really key note here is when you get to the point where your brain can no longer regulate your temperature, fever medications are not going to work. I can give all the Tylenol in the world, but my brain is like not receptive to that. So you have to do all environmental things, cooling the room, ice packs, the external stuff, the cool fluids. And we have these machines known as Alciuses, and we use them for like a hypothermia protocols, but we can also use them to cool patients. And it actually has like a balloon in their aorta that we can change the temperature and kind of cool them from the inside out if we need to. We usually, of course, do least invasive first. So usually we're starting with just the other measures, etc., to cool them down. So let's talk about on the other end, cold-related emergencies. These can be localized, things like frostbite, or systemic, things like hypothermia. And the risk factors here are very similar in some ways, where like the age, very young and very old, same reason, as everything, as you get older, everything goes to crap. When you're young, you can't regulate. Any sort of prolonged exposure to cold temperatures, so those that live up in colder climates, be more at risk. Being homeless, just in the nature of, because a lot of homeless people, they're not going to have the same, the heat and other things that they need, especially at certain times of year. Having any sort of issues with your blood vessels, that would be diabetes, because remember that glucose attacks the blood vessels, breaks them down, etc. Any vascular disease. Alcohol intoxication, and smokers as well. And I usually, when I talk about hypothermia, I always talk about the patient I had that at JPS one time that it was one of the rare times in Texas that we actually have really cold weather, like truly cold weather. Like it gets cold, but you usually don't get that cold. But it was probably one of the coldest winters since I've been here. And this guy, he had to decide to pay for alcohol or to pay for his heating bill. And he decided the alcohol because he thought the alcohol could keep him warm. But he ended up coming in, and I want to say his temperature was something like 86 or 84 degrees or 82. It was something incredibly low. It took 3 days to warm him up. But this is just to show that, like, a lot of times he had a lot of those factors. He had, like, I want to say he had some sort of vascular disease. He was also drinking to try to keep himself warm. I believe he was a smoker. So it's definitely very hard, so pretty much his his electric was out, so his heater wasn't working, and yeah, he ended up with really severe hypothermia. So, when it comes here, you know, we're talking first about frostbite. Frostbite's a localized cold disorder. So this is where there's the tissue itself is frozen. So you always think of like the mountain climbers or people that are, you know, climbing cold mountains, that this could happen to. But it can happen to anyone. It can happen to someone, you know, a homeless person on the street, etc. But the tissue itself is getting frozen. The cold stress leads to vasoconstriction and reduced blood flow. So think of this a lot like ischemia, or the tissue can die. I wouldn't worry too much about the difference between superficial and deep, but you know, superficial, waxy pale, yellow skin, it can be blue or mottled. The skin actually feels crunchy and frozen, and it can have numbness, tingling, and burning. With the deep, the skin is white and hard, insensitive to touch. And that's, you know, it really shows you the injury. Like when it's superficial, they still, like, the nerves aren't as affected, so they still have the numbness, tingling, etc. Whereas once you get deep, like it's to the point now, like where there's like, you know, no blood flow to the skin, which leads to them to not even be able to feel that. Treatment wise, we want there's a big focus because this is a skin tissue issue, so we're worried about infection prevention and keeping their integrity of their skin. So we do not want to squeeze, massage, or scrub the area. We want to remove any constrictive clothing, jewelry, especially like rings, things like that. We're going to do really thorough wound care. Pain management's a big thing. This hurts for a lot of people pretty severely. Tetanus prophylaxis, because this is kind of like an open wound, it's really high risk for tetanus. So we're going to evaluate them and see when they had their last tetanus, etc. Talk about that in a different video. And then elevation. Now I know this is going to sound counterintuitive because most people think, oh, I want to like make it dependent, or like, you know, have it like to gravity where stuff is coming down. And so at the end of the day, what do you call it? Yeah, so anyway, so effectively we don't want it to be dependent or to be, you know, going downward, because while it seems like, oh, that's going to help with the flow, there's a lot of swelling and inflammation. So the point of the elevation is it's going to help to decrease the inflammation, which allows for better blood flow, and it's also going to decrease the inflammation, which will help with their pain. So elevation is good, and we want that for frostbite. Remember, back to acute musculoskeletal, the only time we do not want elevation is when we suspect compartment syndrome. And then thermoregulation. So it's also, the tissue is cold, so we usually want to immerse it not in hot, but warm water. Warm water is what we're going through. And then we're going to warm everything that goes into the patient, oxygen, IV fluids, etc., to help otherwise warm them up. So hypothermia wise, this is where it's a systemic coldness, if that's a word, cold disorder. Their core temperature is below 95. They may be shivering, and everything is low and slow. So they are sleepy, confused, they have low respirations, or you know, they're not breathing many times per minute, their heart rate's low, they have bradycardia, hypotension. We're going to treat this as like the opposite of hyperthermia, and we're going to warm the environment. So we want to warm everything, heating blankets. Like you can see, this patient has a bear hugger on them here. And then with most high flow O2, we can humidify and heat it, so we can warm them up that way. We do warm fluid resuscitation, warm up their fluids. Do not put them in the microwave. We can get them from pharmacy warm. They have like fluid warmers and other stuff. And there's also like you can get it, like some hospitals might do like warm from pharmacy, but what most people do, there's actual box, and then you put your tubing through this fluid warmer. And it's the same stuff we use for like blood, like it's called like a blood warmer. And then it warms it through the tubing as it's going through. So you don't, please don't put your bag in the microwave. I don't know what would happen. It might not be that big of a deal, but you don't need to do that. So heating devices like this bear hugger, you always want to warm the trunk first, or the central area, and then the extremities. Because otherwise it can shock can happen. So if you warm the extremities first, and then all of a sudden then your heart's kind of, I don't want to say frozen and be dramatic, but it can lead to shock. So you always, and this is what I'm going to say is that it's not that I'm sitting there, I'm like, oh my God, I've got to warm their trunk first, take their arms out of the bear hugger. But I'm not going to just, you know, keep like one part of their body warm and then avoid their middle. So pretty much usually we just put them under the bear hugger. We also want to keep the patient's head covered, because you can lose a lot of heat through your head. So we usually wrap a warm blanket around their head. And then a lot of taking care of this patient It's going to be, again, fluid and electrolyte balance. And hemodynamic stability, we want to check an EKG. This is that Alcius machine I was telling you about, and we use this a lot more often with cold people than with people that are too warm. But it helps us to kind of increase a patient's temperature. It's where that, like I said, it's a catheter that goes in through the groin, and it's a balloon that is inflated. It's in the aorta, and effectively it helps to circulate certain temperature fluids, you know, just through this balloon to help to kind of in your core warm you up. Things can get messed up with coagulation or how well you're clotting and stuff like that as you are getting rewarmed. So the nurse just needs to watch really closely for changes and be watching, you know, for any signs of instability. Because like, as much as it may seem like, oh, like, so what I'm trying to say here is that with a patient with hyperthermia, we usually rapidly decrease their temperature. We really want to get it down quick. With a patient with hypothermia, we are slowly increasing their temperature over time. So we're not rushing to any sort of extremes, etc. with this. We're just taking our time and slowly increasing their temperature. And when I say taking your time, I don't mean we're getting crazy, but we don't want to raise it up super quick because it leads to a lot of instability with their blood pressure. It can lead to instability with their labs and electrolytes. It can lead to instability with their clotting. So with these patients, like usually if I have a patient that I'm rewarming after like a hypothermia protocol and stuff, I'm warming them up by like, you know, like 0.5 degree every so often, because again, the body, when it's warming up, like everything starts to wake up and ignite, and it can definitely lead to some problems. So anyway, slowly warm them up per the doctor's orders, etc. Let's see if there's anything else I want to say. And I mean, every you know, every protocol is different. So I'm sitting here, I'm speaking from my experience that usually we warm slowly. I mean, there may be newer protocols now, so I don't want to like you to get thrown off by wording or anything like that, because we don't want to just be chilling and be like, hey, maybe tomorrow we'll raise them another degree. They're usually, their temperature as we're, you know, affecting their environment is going to start going up. But we don't want to get too crazy with it, because we definitely want to make sure that we're not, if they're super low, we don't want them to have that that instability. So we're going to just be watching their labs closely, watching their assessment closely. They need to be on continuous ECG monitoring, looking for any dysrhythmias as their body starts to wake up and rewarm. Okay, I think I'm going to shut up now. I hope this helped. I'll see you for the next one.